Thank you for joining me today. In this video, we are going to learn a geriatric psychiatric practice, aging, neurocognitive disorder, late life, mental illness, and comprehensive geriatric psychiatric care. Geriatric psychiatric care focuses on the assessment, diagnosis, treatment, and prevention of the mental health disorders for older adults. As the global population ages, psychiatric clinicians increasingly encourage the complex presentation that involves late life depression, anxiety disorder, neurocognition disorder, psychosis, substance usage, sleep disturbance, medication-related psychiatric symptoms, grieving and adjustment challenges, medication, medical, psychological interaction. Older adults are not simply older version of a younger patient. Aging produces a significant changes in brain structure, in neurotransmitter system, in medication metabolism, in cognitive function, in social roles. If they were productive person in the society, and now maybe they are retired, so social roles changes, physical healthy changes, and family relationship changes. Psychiatric practice working with all psychiatrists working on older adults must integrate psychiatric expectations with the neurological of the age, medical complexity, functional assessment, caregiver systems, ethical decision making. Central goals of the geriatric care are psychiatric care are preserving independence of the patient, maximizing the quality of life, maintaining dignity, and reduce the suffering, and promoting healthy age. In this video, upon completion of this video, we are going to describe normal versus pathology aging. We are going to perform a comprehensive geriatric psychiatric assessment. We are going to differentiate depression, delirium, and dementia. 3Ds: depression, delirium, and dementia. We are going to differentiate those three. We are going to understand major cognition disorders. We are going to apply evidence-based treatment approaches for late life psychiatric disorders. We're going to manage psychotherapy medication safely in older adults. We are going to learn how to assess the capacity and ethical issues. We are going to also assess a caregiver burnout and family stress and family system. We are going to develop an integrated psychiatric care plan for older adults. So the function of the geriatric psychiatric is defined is the branch of a psychiatric that focus on mental health conditions correlate in adulthood, typically involves individuals aged 65 and older. However, geriatric principles are determined more by the biological aging, functional status of the patient, cognitive ability, medical complexity, than by the chronological age alone. So normal aging versus pathological aging. Understanding normal aging prevents overdiagnosis and underdiagnosis. Overdiagnosis and underdiagnosis. Normal cognitive aging common changes include slow progress of speech, mild difficulty recalling the names, large time need to learn more information. That is the normal. But if that is instead of low process speech, how about if that is long process speech? That's different. Instead of mild recalling the names, if severe difficulty calling names, that is different. How about if it's longer, needed to learn new information, and if they forget the new stuff? That is not normal aging. However, judgment remains intact even when the person is aged. If the judgment is impaired, that is not normal. Also, independence is preserved. Daily function remains stable. How about if the daily function is not stable? That is abnormal. But pathological cognitive aging. What is the pathological cognitive aging? It suggests illness when there is a progression of a cognitive decline. That's not good. Loss of independence, impaired judgment, all these are not normal aging. Difficulty managing daily activity, those are not normal. Examples include mild cognitive impairment, major neurological disorders. Those are not normal. So, neurobiological aging affects multiple brain structure. Brain structure that changes normal aging may involve reduced brain volume. So the brain volume is reduced. Changes in the white matter is integrated. And alter connections. More significant changes occur neurodegenerative disorders. Neurotransmitters that changes in aging is associated with the dopamine changes, serotonin changes, acetylcholine changes, and norepinephrine changes. Clinical relevance of these changes include the mood. It influences mood, it influences cognition, it influences the sleep, and it influences medication response. Thus, we need to do comprehensive geriatric psychiatric assessment. Older adult requires multi-dimensional assessment. Components of the assessment include psychiatric history. You want to assess current psychiatric symptoms. You want to assess the previously disorders or mental illness. You want to assess the medical history. You want to assess the psychotherapy history, if they had a psychotherapy before. You want to assess if they had a hospitalization, if they had a suicidal ideation or attempt. Medical history is important because psychiatric symptoms may be caused or worsened by the medical illness. You want to assess cardiac disease. You want to assess neurological disorder. You want to assess chronic pain. You want to assess cancer, sensory impairment, medications. You want to review the medications. Older adults frequently experience polypharmacy. That is many pharmacies taken together. They also experience drug interaction because they are taking multiple medication at the same time, from psychiatric medication, depression medication, anxiety medication, heart failure medication, kidney failure medication. All these medications can interact and cause side effects. So we want to assess that. So you want to assess the medication adverse effect. We want to review the prescription medication. We want to review the over-the-counter medications. We want to also review the supplements that they are on, because the supplement, over-the-counter prescription medication, all this together can interact and cause side effects. We want to also assess if there is alcohol usage or substance usage. We want to also assess the functional. We want to evaluate activity of a daily life. That include if they take a bath, if they are dressing themselves, if they are eating by themselves, if they are tolerating by themselves, or do they need help. Mobility. We want to assess how their daily activity of daily life is. We want to also assess instrumental activity of daily life, daily living, and instrumental activity of daily life living include managing financially, managing medication, transportation, shopping, cooking. The loss of instrumental functioning maybe is early sign of cognitive decline. We want to also assist the geriatric mental status examination. We want to use that. The examination requires attention to cognitive and function. We want to assist the appearance and behavior. We want to assist the hygiene. We want to assist the mobility. We want to assist the trauma risk and psychomotor changes. In speech, we want to assist the frequency. We want to assist the where finding difficulties like a Parkinson and Alzheimer's and dementia they have, where finding difficulties, language changes, we want to assist language changes, we want to assist mood and affect late life. Depression may present as sadness, irritability, fatigue, withdrawal of the society, and somatic compliance. We want to also assist the thoughts process. We want to assist the organization. We want to assist the slowing or confusion. We want to assist the cognition. We want to evaluate attention to details, memory, orientation, executive function. We want to also assist the insight and judgment. We want to assist the understanding of the illness and safety awareness and ability to make a decision. Cognitive screening and assessment. For cognitive screening and assessment tests, for the cognition screening and assessment, we want to do a cognitive screening assessment, but does not replace the clinical evaluation. The common cognitive screening tools include many mental examination that assist the orientation, registration, attention, recall, language. We want to assist the mental cognitive assessment, more sensitive to mild cognitive impairment. We want to evaluate executive function, attention, memory, visual aspect, skill, clock, drawing test. We want to assess executive function and visual spatial ability. We want to assist the dementia. Dementia is an acute distress in attention, awareness, and cognition. It is usually underlying a medical condition. So the delirium is caused by the underlying medical condition. Clinical features of delirium include acute onset, course fluctuation, courses, impaired attention, and change of the level of consciousness. Common causes of a delirium include drugs, medications, electrolytes, infections, reduced sensory impairment or input, endocranial pressure. We want to assess that. So we want to assess if this is caused by the medication, like the sedation medication, polypharmacy medication, electrolyte. We want to assess the sodium, metabolic disturbance. We want to assess the urine, pneumonia. Pneumonia and urine both cause delirium. We wanted to compare the delirium with dementia. Delirium is the acute onset, but dementia is graduate onset. Delirium is a fluctuating courses, but dementia has a progression. Delirium has a markedly impairment, while dementia has often perceived earlier. The cause of delirium is medical, when the cause of dementia is a neurodegeneration or other neurological causes. Major neurocognition disorders involves a significant decline in interfering with the independent. Domains affected by include the memory, it includes attention, it includes social contacts, include language, includes executive function. Alzheimer's disease. Alzheimer's disease is the most cause of dementia, and it is associated with amyloid deposit, tau pathological, tau pathological, and neurodegenerative. That is the Alzheimer. Clinical progression. Early Alzheimer is the memory impairment. Early Alzheimer symptoms is the memory impairment, difficulty learning new information, and mild Alzheimer symptoms include language problem, behavior changes, functional decline. Late stages of the Alzheimer include severe dependency and communication impairment. Treatment. The goal is to slow the decline. There is no treatment, but the goal is to slow the decline and improve the function and manage the behavior. And medication category may include cholinesterase inhibitor and glutamate modulating medications. Vascular cognitive disorders is associated with stroke, CVA, and vascular risk factors. Features include stepwise decline, executive dysfunctional. Management include risk factors control, cognitive support, and functional interventions. Lewy body dementia. Lewy body dementia clinical features include fluctuation of the cognition, visual hallucination, Parkinsonia symptoms, REM sleep behavior, improved medication consideration. Patient may have sensitivity to dopamine block medications. Frontotemporal cognitive disorders often present personal changes, behavior disturbance, and language impairment. Memory may initially be relatively present. Depression in older adult. Depression in older adult commonly, frequently, and recognized in orderly. In many, it may present with fatigue, sleep disturbance, appetite changes, pain, compliance, and cognitive compliance. Late depression risk factors include medical illness, loss of spouse, social isolation, disability, previous depression, and chronic pain. Assessment considerations: you want to evaluate suicidal ideation, cognitive symptoms, medical effects, and medical causes of the depression. What are the treatments? Treatment include psychotherapy and pharmacology. Psychotherapy is based on evidence-based approaches include cognitive therapy, problem-solving therapy, interpersonal therapy, and medications that you want to consider is the lowest. You want to start the lowest dose. You want to titrate slowly and increase slowly. You want to monitor the increased monitoring. You want to monitor the fall. You want to monitor sodium abnormality. You want to monitor drug interaction. And you want to monitor bleeding risk when indicated. For anxiety disorders in older adult, anxiety may present as excessive worries, restlessness, and sleep disturbance, and somatic compliance. You want to assess and evaluate the medical causes of this anxiety, medical side effects, cognitive disorders, and treatment approaches include cognitive behavior therapy, relaxation training, appropriate pharmacology for anxiety, late life psychosis. Late life psychosis in older adults require carefully evaluation, and causes include cognitive disorders, medication side effects, delirium, medical diagnosis, and primarily psychosis disorders. You want to evaluate hallucination, delusion, cognitive status, and functional decline. Sleep disturbance and sleep disorders in older adults. Common problems are insomnia, circadian rhythm changes in older adults, and sleep apnea and REM sleep behavior disorders. You want to evaluate the sleep schedule, medication side effects, coffee usage, pain that they are complaining about, mood symptoms that can affect their sleep. Treatment to consider include cognitive behavior therapy, sleep hygiene, and treatment of the underlying medical condition. Substance usage in older adults include substance usage disorders may overlooked in older adult, and risk factors include retirement, loss of spouse and work isolation. So people use substance usage in older adults to cope with the stress of getting retired, losing function, losing spouse, losing work, losing independent. Social isolation is the risk factor that encourages them to use a substance, and chronic pain can be a risk factor for them to use alcohol or opioid, and prevalence. So you want to assist the alcohol usage, opioid usage, prescription medication misusage, and sedation medication usage, and anxiety medication, anti-anxiety medication usage, because they have anxiety, they have sleeping disorders, they may use that medication and get addicted. Suicidal risk in older adult. Older adults presented in high-risk population for suicidal ideation. Risk factors include depression, chronic illness, pain, and loss of independence, social isolation, fire, accessibility, and previous attempt. However, you want to also assess the protective factors that include treatment management, social connections, if they have social connections, and spiritual and personal belief. If their belief and spiritual is strong, is the protective factors against the suicidal ideation. If they have a connection, that is the protective factors, and treatment management can help them to cope, and meaningful activity can lower the pain and stress and depression and will be coping factor skills. Okay, psychopharmacology principles in older adult. Older adults requires caution prescription. Older adult requires a caution prescription. Be careful prescribing for older adult, because the pharmacokinetics changes happen in aging may alter the absorption of the medication, distribution of the medication, metabolism of the medication, and elimination of the medication. So pharmacokinetics changes with age. Also, pharmacodynamic changes with age. So older adults may have an increased sensitivity to sedation medications, and they will be more sedated and risk to falls and confusion. They are also sensitive to orthostatic blood pressure, orthostatic hypotension, and they have anticholinergic effects, movement disorders such as the psychiatric medications. Prescription principles include start slow and titrate slow. Okay, review the regulations. You want to evaluate the effectiveness. You want to evaluate effectiveness of the medication, and you want to evaluate the advice, effect, and continue need. Do they need the medication? If they don't need it, you want to discontinue. You want to minimize polypharmacy. Use the fewest medications needed. Anticholinergic burden. Anticholinergic medications contribute confusion to older adults. Cognitive declining. It contributes to constipation, urine retention, falls. Older adults are particularly vulnerable to anticholinergic medications. Capacity, guardian, and ethical issue in older adult. Older adult may face questions regarding medication decision-making capacity, financial decision-making capacity, living arrangements, and safety. You want to assess the capacity of the older adult. You want to evaluate and understand. You want to evaluate understanding. You want to evaluate the appearance, reasoning, ability to communicate their choice, caregiver assessment and support. Caregivers may experience stress, depression, financial burden, and burnout. So clinicians should assess caregiver capacity, support system, and respect needs. Integrated geriatric psychiatric care. Effective care requires collaboration between primary care, neurological, geriatric, pharmacology, social service, and family support. Clinical case presentation that I have is you have a 82 years old patient present in increased forgetfulness, medication errors, social withdrawal, and sleep disturbance. Family support is she is not managing things the way she used to be. That's what the family tell you. You want to evaluate the progression, cognitive declining. You want to evaluate the functional impairment. You want to evaluate the depression symptoms. No acute. Also, you want to evaluate no acute delirium signs. If there is a delirium signs, you want to send them to the emergency because it's medical emergency. Clinical formation possible is a major cognitive. This is possibly is major neurocognition disorder, and comorbidity is the late life depression, and major cognitive disorder. What is the treatment plan? Treatment plan includes cognitive evaluation, medication review, safety assessment, depression treatment, family education, and care coordination. A certain changes in cognition should be considered a delirium enter provided otherwise. Functional decline is often more clinically significant than cognitive testing score alone. Older adults frequently present with depression through the physical compliance rather than sadness. Always review the medication before diagnosing psychiatric symptoms in older adults. Prescribe for older adults requires balancing symptom improvement and the safety. The goal of geriatric psychiatry is not merely only life longer, not merely life longer. It is better quality of life. You don't just want to increase the lifelong, but just you want to improve the quality of life. Four questions include: what distinguishes delirium from dementia? How you differentiate between delirium and depression? How you differentiate delirium from dementia? Delirium has acute onset, fluctuating courses, and from attention impairment, while a dementia is a typically gradual process. What cognition domain is often affected by early Alzheimer's disease? Memory, particularly difficulty learning and retaining new information. What is the key prescribing principle in geriatric psychopharmacology? It is starting with the lowest dose and titrating slowly. Monitor closely for the side effects. What are the important components of the functional assessment in older adults? It combines active of daily living and instrumental active of daily living. Why must psychosis in older adults be carefully evaluated? Because it may result in neurocognitive disorder, delirium, medication side effect, medical illness, rather than primarily psychological disorder. Geriatric psychiatry requires integration and understanding of the aging, neurological, medical complexity, cognition, psychosocial factors, and psychosocial factors. Clinicians caring for older adults must recognize that psychiatric symptoms often appear different in late in life and require carefully differentiating from medical and neurological disorder. Advanced geriatric psychiatric practice integrates comprehensive assessment, cognition evaluation, functional assessment, safe prescribing, ethical decision making, family collaboration, interdisciplinary care. Ultimate goal is to preserve independently, protect dignity, reduce suffering, support meaningful quality of life through the age process. Thank you for joining me today. I would love to see you my next video. Thank you. Subscribe and join me again.